ठीक है तो दोनों साथ साथ करने जी अस्सलाम वालेकुम thank you for the opportunity. I'll just get on with it. There's much to go through. Please bear with me because we're working on two platforms, face-to-face and online. So there might be a lag in either one of them. So this is a randomized control trial that is started, and we are one of the sites where this is just launched. And this, I've taken the opportunity of the grand round more as a public appeal to pitch in and help out with the trial. Yeah, let me see how this will. Guys, can you help me move this? How will this move? The online one, Ikra? This is not moving. It's moving now. Okay, so the burden of disease is such that nearly a quarter of people die in the first year after a hip fracture. And as far as loss of function and independence is concerned, up to half are unable to walk independently. More than half require assistance, and about a third are totally dependent either on their relatives, family, or are in a nursing home. So there's been a lot of research over the last at least a decade and a half, and I've just picked a few maybe because I know those people, or there were enough numbers because obviously in orthopedics trials logistically become very difficult to run. So about 2,000 patients were looked at, a prospective study where post-operative mortality was significantly higher if it took longer for these hip fractures to be operated on. Early surgery within 24 hours was reduction in mortality, and this was a systematic review by your friend. You've got that name there, PJ Deveru. And surgical delays is associated with significant risk of pressure sores, and pressure sores is a big problem for us in terms of infection, mobility, and eventual. It's a testing time having have a pressure sore for the relatives and the patient themselves after what they've fallen, and it is a fairly big burden. And you can see they've gone up to about 200,000 patients in the systematic review. So yes, there is enough impotence. Shorter time to surgery is associated with lower rates of post-operative complications. The cubitus ulcers, urinary tract infections, thrombosis, pneumonia, cardiovascular event. This is my usual spiel with patients who come into the emergency room, and I tell them the reason why we're doing this quicker is I'm not going to get them any better from what they are, but I would like to try and avoid further complications. The team we've got, so I'm the principal investigator, Mir Wahid is the co-investigator, and Dr. Sabura, Hassan, Dr. Kenza, and Akash from the ER nurse. We'd be probably the points of contacts if you had any concerns with regards to recruitment. So again, the rationale comes from the HIP Attack-1, which was actually, where am I going? Okay, so I'm still lagging behind between my, probably try to do this. So among patients with hip fracture accelerated surgery, what it showed was that it didn't quite stop the course of nature. It was what was going to happen to them was going to happen, but there was no evidence of further harm. Accelerated surgery did lower the risk of delirium, did lower the risk of UTIs, and their pain scores were slightly better. But most importantly for us, they were able to get up and going better. They were allowed to wait much sooner, and they had a shorter hospital length of stay, which evidently meant that they were having less DVTs, which meant that they were not getting hospital-acquired infections and catheter-related or tube-related infections, phlebitis, and whatnot. Accelerated surgery did demonstrate a slight mortality advantage with elevated troponins before randomization. And anything else you need to ask this man because he was involved in the HIP Attack-1 when it happened in Shifa. So this is a forest plot. And I mean, looking at this, it just gave them a hint. I mean, you can look at the confidence intervals aren't putting enough confidence as far as I'm concerned with this subgroup analysis. The overall, the weight looks reasonably well, but it did, they might have found it as a ray of hope that what if we look into it, we may be able to make a difference where accelerated surgery did, was in favor, even if the troponin levels were randomized. So hence the reason why they wanted to come up with a question. So the question is, uh, patients with hip fracture and baseline elevated troponins will benefit from accelerated surgery. Obviously, where are we? There? Yeah. And let me just. Yeah. Absolutely. Yeah. Yeah, when I said that, I didn't inspire much confidence as far as statistics is concerned because they're working on the numbers now. Yes, but you're absolutely right. It dictates the fact you just get on and do it. Where were we? So the principal question in hip fracture patients who also have an elevated baseline troponin, is accelerated surgery superior? And obviously they want to look at the primary outcome, which is whether they die or not within 3 months of randomization. So trial design was an investigator-initiated multi-center international randomized control trial. They want about 1,000 patients. They've got about 50 sites in 15 countries. We're one of them. The intervention is, you see that right. So goal of surgery within 6 hours of hip fracture diagnosis. Thankfully, it's not 6 hours from hip fracture, but when we diagnose it. That is very, very helpful for our small setup, and standard care is to do it whenever we normally do it. Intervention, so the patient comes into ER. So we've got the ER team, thankfully. So this was mainly just so that we can let everybody know, because this is starting. So they come into ER, they've fallen and you're suspecting hip fracture. We're still not quite sure. I need to check with Sabura. If we're suspecting hip fracture, do we get on and do this? Or once the diagnosis is made? So that's some logistics that we might need to work. Obviously, we check if they're eligible, whether they have a fracture or not. The eligibility we'll talk about in a second, a diagnosis, and then check whether OR can accommodate. We randomize either into accelerated or standard care, as this is giving me almost an epileptic attack right now. Rapid medical clearance and OR access, standard medical clearance or OR access, and then call them up in 90 days to check what's happening. Primary outcomes, all-cause mortality 90 days after randomization. Secondary outcomes, are they able to walk about 10 feet across the room without human assistance? Time to first mobilization, standing and weight bearing. So yes, we fairly. Oh, sorry. I'm lagging behind a little bit there. Sir, we're actually very grateful. So it's up to you. Yeah, G. G, how you can use this. So and then we're also looking for if they've had a heart attack or not, if they ended up into cardiac failure or had a stroke, vascular, non-vascular mortality. I suspect what they're meaning is a DVT was rushed up into a PE, but I suspect whatever secondary outcomes come, we're going to log them with your help as well. You guys, you'll be doing it if it's a medical patient or a surgical patient or a stroke. So next clip, please. Yeah, and obviously, what is important for the patients and maybe our insurance team as well is their length of stay. Is that gotten longer or shorter? And that is fairly relevant across the planet. Delirium, very important for us, and pain, certainly. The reason why we're doing it to improve their pain, if not rid them of it. Next click, please. Thank you. And another click. Thank you. Tertiary outcomes. If they've ended up having another cardiac event and has led them into a weaker heart, which has needed some form of intervention. And, you know, this the B in our bonnet is the DVT and PE we're terribly afraid of, at least as orthopedic surgeons. Next click, please. Infection. So we do need to document if there is any post-operative infections. And obviously the names and contacts will help you as to log it where and how. So documentation is absolutely essential from the medical team on the floor. Life-threatening injuries, I suspect that will pick up from when they come into the OR or a major event has happened through our morbidity and mortality meetings. Orthopedic complications, yes, we'll keep an eye out for them and log them, which is we needed to go back for an operation. We've recently had somebody who we've done a hip fracture treatment, gone home and come back with a swelling and had to go back in because we suspect we drilled through the profunda femoris. And they went and cleared that, and she's back and she's up and about. So we've just been talking about it on our WhatsApp group about acute kidney injury and acute renal failure. And, you know, this is not uncommon, at least in my practice, with these crumbly patients. And hospital readmission, obviously very, very important. Length of critical care stay, length of rehab stays, and days alive at home, which I suspect we'll find out at the 90-day telephone conversation. Quali, I suspect they want to do this quality of life that eventually HIP Attack-3 might have cost per quali on doing these quicker, and would be very, very interested in knowing about those. Eligibility criteria. Thank you. Inclusion criteria, age more than 45 years. So that makes it easy for us. That's what we normally get. Diagnosis of hip fracture during working hours. So that works slightly better for us as far as logistics is concerned, with a low energy mechanism requiring surgery. So fall from standing height, tripping over a carpet, getting out of a car and falling, slipping in the toilet, have a dizzy spell and fall, that all comes into it. Absolutely. And that and that was the question when the Canadians came to us when we had a Zoom meeting and we talked about the logistics, because we just but so ideally speaking, what normally happens is they either trip off first thing in the morning when they get into the toilet or go for wuzu for fajr, or it's generally in the middle of the night unless they're out and about. And in the middle of the night, if they've gotten up because they've got heartburn, they want to go to the toilet, you would know better. Those are the times in the morning when they end up having a cardiac event, and that's when they trip over and fall.
So the concern at that point was, what if a patient comes at midnight? So what is 6 hours from there? So what they've said is, it all depends on when the diagnosis is made. So it will happen when they've made that phone call to us. We'll try not to pick the phone call till it's 8 o'clock in the morning. No, kidding. What I'm trying to say is, it will happen once the diagnosis is made, and the clock starts from there.
You say that diagnosis is the actual diagnosis.
Yes. So as it stands, no, of course. So let's say so at this point, at the moment, it's either Bahid or myself who are designated. So let's say Dr. Nicola is on call, Dr. Pharmacist is on call, and a hip fracture comes in, and he's probably been made aware in the middle of the night that there is a hip fracture which is coming in. But I may not have seen it to make a diagnosis to start the clock. Yes. So that's one.
And they've also, there is, I don't know if I should say flexibility, but the number crunching with McMaster is such that it may almost work very feasible that even if once we know what time the patient's going,
Number of patients
Yeah. So I don't know about your stats, but I'm on an average looking at about 1 every 7 days. But so this, when they asked us to come over and join, they asked us these specific questions as to how much, and at that point, enough the five of us, we were doing enough for them to offer. Yeah, randomization.
by the way, just to say, let the junior doctors know that now when you go abroad, and if you've been part of randomizing or recruiting patients for randomization, you get a mark. So stay involved and remain involved. So inclusion criteria, troponin elevation. So if there's no troponin elevation, let them be in peace. Oh yeah. So yeah, we'll come through the exclusion criteria. Yeah. So we'll talk about that in a second. And then number 4 is obviously, I think I'd like, the research team work with the informed consent as to how, because they'll be very well trained by now with all other randomized trials to get this information out. If they were worried in any way, I'll get involved to help the patients explain. Patients must meet all inclusion criteria. So like I said, more than 45 years of age, fall from standing height or low entry mechanisms. Now, this is something where, obviously, it may be that hip fractures, fractures proximal in the portion just below the femoral head and no more than 5 centimeters below the lesser trochanter. If you get 10 orthopedic surgeons on a table, you'll have 10 different views about where is what. So let's say Dr. Rico said, inclusion criteria, I don't, then maybe I come to you and say, why do I think so? I suspect we won't have many of these, and we'll end up agreeing on most. So again, for ER team, mid-shaft fractures, distal third fractures don't come into this. So even if it is touching the lesser trochanter, just check with us. I don't think if it's touching if it's a spiral and going into lesser trochanter, I don't think it'll be added into it. It'll be lesser trochanter and up, but it may be worth just checking with us. Including all major type of fractures, femoral neck, intertrop, subtrop. So subtrop is included. Now, the thing with subtrochanteric fractures, just so you guys know, it is almost always pathological unless proven otherwise. So it could be bisphosphonate therapy, but most of the times it's either osteoporotic or they've got cancer there. It does not have an impact, but we will be sending reamings. We normally do send reamings to check for diagnosis, and we end up finding primaries elsewhere. So that will be logged as well. Troponin levels definition. So site specific. Shagul was involved and she gave us numbers, and I have, as an orthopedic surgeon in the last 5 years, yet to see an elevated troponin or as in my patients. or to analyze it. So I'll be needing your help with that. Informed consent, written or verbal. Yeah, either by patient or by a legal representative is approved. I think because they've done it across 50 sites, ours will be written with a lot of verbal. And is that correct? Isn't it? Well, Sabura isn't here. She might be on the online bit. Exclusion criteria, like so. Why is this not just slow down? So if they're on therapeutic dose, so aspirin, clopidogrel, and prophylactic anticoagulation doesn't matter. If it is they're on some form of therapeutic dose because they've got a metal valve or they're on DVT or PE or whatever, then they are excluded. Patients with a periprosthetic fracture, they've already had hip fracture surgery and they've broken it. Open fractures do not count. Polytrauma or bilateral fractures do not count. Patients requiring an emergency surgery for another reason and they found a hip fracture does not come in. Let them go. We're moving out of that. This is quite important, I think. Now this is where you it may get tricky, where if they've come into the ER and you found with them with ST changes and whatnot, and they need to go to for any form of intervention, let them go. Well, they won't be included. Obviously, yeah, that is fairly understandable if they don't want to get involved, and I suspect we'll have quite a few of those. It all depends on how the recruiting team works around them. I suspect it may mean money. Sorry, yeah. Previously, yeah. Yeah. I mean, fairly self-explanatory, but I suspect we'll have a few of these as well. I suspect that may happen because we've enrolled them and they've gone and thought about it and they've gone to a different hospital and I've had them coming back again, so they don't get re-enrolled. We might have to check with them how we play with that. Okay, so next slide, please. So response, no to all criteria. Again, it is doing with therapeutic anticoagulation, especially if there is no reversal available. But thankfully, our resident hematologist involved, we might be getting some help from him if this was the case. But they get excluded anyway. I suspect he'll slash them out of our the recruitment as well. And patients requiring emergency surgery or life-saving surgery, you can see quite a few life-saving procedures here. They won't be involved. Next, logistics and operations. Right, so this is, thank you very much. So again, this is where, the emergency team gets involved because they come first straight to you. If you find a hip fracture, call the research department. That is probably it, because then you can start doing troponin screenings. We get x-rays done, which are fairly rapid as far as our institution is concerned. Once you got the x-rays, we're all fairly accessible for you to get a diagnosis. Now, this part from here onwards may get tricky as to how we arrange booking. How do you arrange booking, sir? If let's say a hip fracture comes to you, how do you let OR know? Do you just call them and book it? Yeah, fine. And yeah, so it's been fair. So we do the same as well. So that seems fairly reasonable. And once the OR booking's done, we would like your help, Ruby, Osman, all of you guys, to if they are randomized, and if they are in the accelerated pathway, we might want to, we might pester you a little bit more than the average, and then decide about whether it's happening within 6 hours or within the usual time frame. So next slide, please, sir. Thank you. Screening, recruitment, research personnel to potential. So it'll be research department. They'll be screening and recruiting. Why is this not working? Troponins from the ER. I'm probably going to skip through all of these. Yes, understandably so. You need all the other blood tests doing as well, which you normally and routinely do in ER. Work with the ED nursing team. So that's the what's his name? Akash is the main man to ask whatever is happening. X-rays get, reasonably quickly done, and so we're fine with this. So this was your question. We we're not quite there, but almost there. When it says average one case a week, where what we found at that point that when we did so, it fluctuates, but it is one within 10 to 14 days. Where were we? So accelerated surgery requires 4-hour accommodation within 6 hours of orthopedic diagnosis. Now that's where our challenge starts, because we don't know where and how we're going to try and slot them. But once this has gone through, we'll go and have a chat with Nadeem Saab, and so hence the reason that everybody needs to be involved in this. We need to go, beg, grovel, whatever, to try to get them a slot available, and there'll be a number of hoops that we might have to jump to get this done within that 6-hour goal. Yeah, absolutely. And yeah, so one, it needs to be reported in the trial that if there are going to be any delays. Two, yes, absolutely. And I think they are compensating a certain amount per patient. No. This is yeah, absolutely. Yeah, and I think yeah. And I think that that's probably what I'm slightly prepared for, where I might have to go and personally speak to a gallbladder if it's slow, if it's delayed for that reason, and hoping to tell them why we're doing this, and it is for a good cause. Generally, people are accommodating if you tell them, if it's a an 86-year-old granny who's quite crumbly, and we'd be very grateful. I've had this when I have to prioritize my list. I do go and talk to them, and most of them are accommodating, but they need to be spoken to. Yes, it's just if I put it, if I don't put a surgery time on it, it's going to be a spinal anesthetic. So that's 190 minutes. Is that fair? Yeah. So you can be. Yeah, but the entire process is about 4 hours, you see. So it's trying to get them. Oh, yeah. Well, we've got to talk to them. And no, but you see, there's every. So once you said that, they have to come from the IPD to recovery. That's a logistic delay. Then and that's we're starting on the top of our voice to try to get them in. And then once we do, then the spinal, whether it's difficult or not, whether they need a heartline or not, and the other things for us is whether the implants are here and they've been sterilized. And two, if they're sterilized and if there's a hole in that drape, it goes back for sterilization. There is a lot of logistics involved with orthopedics. Sadly, that's the problem. It's not sliding patient. So it's just, but yes, those are, and that's what when we started, we said that this may bring us, all of us, closer, helping out, the quality of service we may be able to offer better to these crumbly patients. So yeah, so the one of the things that they said that this is not black and white, and normally these are great acts that happening while the meeting was happening. As a very orthopedic surgeon, what I thought through that was that almost once when you've listed it, you can pretty much randomize it in that fashion. And so let's say if you put it for 10 o'clock, I may have that flexibility to make that decision knowing when you put it in. So that's one. You might have all the things ready for 9 o'clock. It may be that it's randomized to standard care. So, I think there's ways where they've covered a lot of things, but we've got to start and find out where it takes us.
So next slide, please. Thank you.
Right. So very quickly, randomization. This is not for you guys, but I'm, just legally bound to let you know that randomization will be happening through a randomization software. Next slide, please. Medical clearance. So again, here we'll need the likes of Dr. Usman, Dr. Rubia, Dr. Yasser and all, that if it's accelerated, we might be pestering you to get in, get all the cardiology. Now, obviously, they will just start here. I'm sure the others who are listening will all come and pester you. Whoever's on call will come and pester you to get us some clearance quicker. So if we are accelerating a patient for surgery, we're only postponing it if it is a serious problem which needed to be treated elsewhere. They are on Beriplex and Optiplex. This PCC was explained to me by Dr. Usman kindly yesterday, and I forgot about 3 seconds later. So here it says avoid preoperative echo to prevent delayed surgery. Do not delay surgery for cardiac investigations. This again becomes rapid COVID test. This again becomes a challenge where we have to negotiate with the anesthetist. This again will be a challenge when we need to let family members know. This, as far as I'm concerned, I tell them this is not going to alter their outcome regardless of what it is. I tell them that I don't know what my expiry date is. All I know is that whatever time I've got on this planet, I want to be relatively pain-free. This is what I would want for your family member. This is not to extend life. This is to keep it, whatever life he or she's got, to keep it comfortable. But, this is again something that we might have to, negotiate with the anesthetist if we can. Myocardial injury management.
Apologies, this slide is, yes, please carry on with this.
This is so tiny that, I mean, even the viewers on Zoom might not be able to pick it up. But this is, this is fairly academic. And I'll move on in the sense that whatever needs doing, we'll have a chat with the Osabura's here if there are any questions. If there are any concerns, we will go back to these and check with them.
Simplified logistics. Again, this is the important bit may just be that once that's the important bit. It says high suspicion it can fracture.
It means that this is where obviously we were talking to the ER team, and now we've got Wahid here as well. Because in the start I'd said that it needs to be a diagnosis should be made, but because it says suspicion of hip fracture, it makes it easy. If you're suspecting hip fracture, get a troponin done. That's probably the tricky part. And then get hold of Dr. Salura. Don't call me. I'm only calling. I'm kidding. You can call me. Consents and whatnot. And accelerated care, we talked about it in great at great length right now. Sorry, guys, at the Zoom meeting, I had forgotten to play this on your side. Okay, stop and think. This is mostly for us as a team. What are our trial working hours? We've discussed it at length, and I think we've come up with a solution with this. Will troponin screening on ED arrival be part of standard care?
What would you like to say to that, sir?
Thank you. I would love that. Will you rapidly triage suspected hip fractures during working hours? We're putting any effort. We've talked about it at length. How we're going to do that? How will you determine OR availability? We've got excellent suggestions from the team here. How we're going to manage that? Who will clear accelerated patients? I think it'll be all of us, isn't it, Dr. Sabura? It'll be all of us in terms of trying to push and get these, but it'll be the reason for this talk is that we'll all be involved. It'll be medicine, anesthetics, radiology, cardiology, all departments will be involved in helping out clearing these accelerated participants, especially OR. What is your communication strategy to move patients through accelerated care pathway? Shout and pester and grovel and, negotiate and do whatever is needed. Have you built a co-investigator team? Sabura has done a fantastic job. She's built a team around us, the A team. Follow-up. So follow-up schedule, we'll have some baselines that need doing. They will have a Eurocall health questionnaire done. Surgical technique, type of implants, they've not necessarily given us a protocol, a template to write out, but I suspect most of that will be written out anyway. Now, the only thing here, which I suspect us orthopedic surgeons need to talk about amongst each other is, will you let them walk 12 hours post-op? Is something that we might discuss amongst each other in terms of, so it may not be non-weight bearing, but at least on documentation, partial protected or full weight bearing, depending on. Perfect. Yeah. Yes, fine. Yeah. Yeah. Yes, fine. So at least we've got something that we can do that. And obviously hospital index randomization, there'll be tests that need doing. If that's as an outpatient, that may be something we might need. I'm blabbering now. OPD team needs to know, because we need to do some blood tests at that point in time. Are these the ones that, Sabura, if they come back in a week's time, would they come to you first, these patients? So that means we can get their blood test arranged from there. Okay, right. So that helps. And then Dr. Sabura's got all of these, and we'll obviously pick the ones that we find. Follow-up schedule, 90-day follow-up. We're looking at where the patient's staying. What are their motor functions? Have they had any falls since they've had their surgery? Their pain scores, Eurocall of some description, what medications and clinical events since discharge. And obviously, the reportable events and interventions. Participant retentions, they'll have a contact form that is filled, and third-party contacts. I suspect we'll have more third-party contacts here than patient contacts. So, if they say family, friend, neighbor, I'd say all of the above if we want to grab hold of them. Withdrawal, we can talk about this, but if they don't want to be in a withdrawal, they want to withdraw, yes, they can withdraw. That is the end of it, as far as I'm concerned. Potential loss to follow up. Now, this again would be something that, as we go through the journey, we'll find out how easy and difficult it will be. And the problem is, if you've got an 86-year-old granny from Kalar Kahar, and if you're calling the nephew, how reliable the information will be, only time will tell us. I'll try to be quick now. Early visit, 90-day follow-up completed early. Protocol deviations, participants randomized without a hip fracture, missing informed consent, fracture resulting from, we've talked about this. We're not going to be putting any of those. This is quite important. If we get a greater trochanter fracture, and if we're not operating on them, they go out of the trial. Unstable patients, no. If we don't have an informed consent, we're not going to be putting them in. If we can't get their secondary outcomes reported, they go out. If we can't get their troponins, they go out, sadly. Missing procedure. Now, this is something where we'll need everybody's help, really, because documentation is something where not just us, everybody on the planet lags behind. We need a date and time of hip fracture. That'll probably be ER. Fracture diagnosis, that'll be once we've had a chat. Informed consent, does that have a time on it? Okay, so that's fair enough. And surgery start, that'll be our, domain. And I'm obviously we do a WHO safety checklist, but I don't think there's, I've ever checked the time. I'm sure they put a time, I've personally not checked it. So that'll be, a challenge as a personal note for myself and orthopedic surgeons. Okay, 90-day follow-ups. Difference in median time from diagnosis to surgery. between accelerated and less than 12 hours. What is this? What is this? So difference in median time from diagnosis to surgery between accelerated and standard care participants within a single site is less than 12 hours. And after a site is randomized, a total of 50. What is I don't think we'll come into this anyway, because it'll either be or it's a black and white, at least for us. Get
Yes. Yeah. So yeah, we're hoping that we've not had this problem. It's been fairly smooth because we're a low volume unit. So we're hopeful that we'll be able to
we may not have this problem. Let's absolutely. Yeah. The enthusiasm is all. And would that have, the orthopedic requirements of a laminar flow? A single, right. Yeah. So, yeah, I think with the amount of workload that OR is experiencing for the last few months, I think that is a welcome change. Yeah, but yes. So in other places which are high volume, like Shifa or other tertiary centers, they end up having a hip list. So all the hips happen in that list. So it's almost dedicated hip list. But I don't think we would require that. Oh, it stopped. So that's good. The wobbling has stopped. Investigate. You win some, you lose some. So yeah, so viewer discretion is advice. People with strabismus or whatever. Investigative site responsibilities. Yes, they keep pestering me about my GCP. I'm almost there, I promise. So this is just so that you know that we've gone through it. They've all got my my credentials, my all orthopedic surgeons, right? That's the challenge. I think no, they're not listed. Yeah, so because it's a challenge for me to finish that online anyway, right? So again, this is just that we're showing to yourself that we're looking into it and we're doing what needs doing. When I say we, it's all Dr. Sakura. Medical trial participants. So obviously qualifications, they've got CVs of the qualified physician and the co-investigator. Ethics review is the ethics team here. I wasn't involved obviously because I was blinded from this, but they were happy that we can get on and do this. They gave us a thumbs up. Thank you for us to get on and do this. Compliance to the protocol. They'll keep me on track, I'm sure. Or keep me and Wahid on track, I'm sure. Open trial, yeah, we can't blind them. So yeah, I can't remember the last, blinding that can happen in orthopedics. Informed consent, ethics review has already seen these, and we've got on and done these. Reports and records, accuracy, completeness, legibility, accurate, completeness, legibility. Please, accuracy, completeness, legibility. This is what we're looking for. Thank you. And progress report. Do we? How does this work? The progress. How are we sharing it with the IRB again? How does that work? And when is that? After how many participants? Oh, end of report. Right. Okay. I thought after every few. Yeah. Yeah, fine. Oh, we go to Calgary. Wow. Oh, good. We go to Calgary. Yay. At least one of it. So I will send Sabura with a big jacket. All I need. It should go. Yeah. It's not fun though, I can tell you, Calgary. Pre- I'm just skipping through all of these, I think. If yeah, this again, it is just so that we can scroll through. I think we'll skip through most of it, sir. Yeah, we can skip through most of this. And this again is for you guys to know, isn't it? This is yeah, very little from our side. And obviously randomization. Can you move on, sir? Yeah. Again, yeah, they'll randomize it for us. Move on again. Why is this not working? Please click. Okay, who to contact? You know all of us, DHE. So you need us we're around. And why is it not working? And thank you. Sorry, it was big, huge, but because this is going to go on for a few months now, at least, now we all know and we can always revert back to it. There's lots more behind this, but we don't need to get involved with this. So I think we need as orthopedic surgeons, we'll need ER, we'll need OR, we'll need physicians helping us out. And I think we can get through this, inshallah. Thank you. It's the component levels. The people with it high, obviously, we very little so, is there any need for that thing that if the criteria is high, so is high? So what they've said is clinical instability. So if clinical instability includes patient who are ending up having acute kidney injury and may need to end up going for dialysis, they're off. So let's put it this way, that the 86-year-old crumbly granny that comes has got long-term chronic kidney disease with a creatinine which is high, they'll still end up needing surgery. And their standard form of treatment would include a physician review, a nephrology review, surgery done, post-op nephrology. All that will be accelerated unless there are clinical indications to say that they're dropping their BP, there is no urine output, they need to be moved to ICU, and then, to cardiac. So I've gone through this. Yeah, absolutely. So the person has come with hip fracture and you've done troponins. That's it. Now, it may very well be that chronic kidney disease patient does not have an elevated troponin. That's not in the trial. So that's one. There one which has got an elevated troponin and they don't have any cardiac problem. That's included. There is one that's got elevated troponin, but a stable cardiac problem. That's included. There is elevated troponin levels, no cardiac problems, and they've got kidney problems, but not needing dialysis, or the creatinine is not making them unstable, included. Yeah, so who said 48 hours? Usually standard, but here if you look at this week, they've done 24 hours. So standard treatment is within 24 hours on this trial. 24 hours. Diagnosis. No. Thank you to the lady orthopedic surgeons. Don't get diagnosis before 9 years. So that's fantastic. So that's fantastic for us. So let me get this the other way around. So what happens is there is an influx of an injury. It gets seen by a certain tier. They get teed up. They get anywhere on the planet. And then they come up to the ward. They're optimized, and then a ward round happens. And then it's not just the diagnosis. It is deciding what to do with that diagnosis. Hence, that delay is added into
That's why they said that it starts from when the diagnosis is made. Because you see, the problem is this patient may have fallen 2 weeks ago in their village and they've been bed bound and then somebody's found out. It's only when it comes in with Dr. Ali Kokar or Dr. Irfan Masood's state, it could be in clinic. He's about to make a diagnosis. That's when he pushes the red button. Yes, that's correct. That's correct. But yes, but that question was posed to the Canadians in the Zoom meeting, and they've got a number of currently ways of working around that.
So our job is to recruit. So thank you for your time. If there's no further questions, this was the longest talk I've ever given in my life.